Okay, I do want to thank Marty for giving us the opportunity to talk about the company. Aligning with what you've heard so far, I do want to spend some time talking about team because it's the team that makes the idea work, and especially in healthcare where we really try to find cures or strive to find cures to diseases like cancer. It's very important to know who are the people behind it and why you should trust us with your monies. Just a little bit about myself. I'm a PhD scientist by training, worked on Wall Street. I began my biotech analyst career at UBS, not a few blocks away from here, Credit Suisse. Moved over to the C-suite in public biotech, small cap. That's where my passion lies, to make a real difference, even being a CFO at one of them. And then moved on to private companies, trying to build them from the ground up. Last one actually used AI to find new targets. All we had was tumor tissues from patients, and we tried to find new targets looking at a huge amount of genetic expression data. And raised venture capital, raised money on both public and private sides, pure venture capital, 70 million of Series A plus B. This one, we want to do things a little differently, a little bit more mission-driven with my other founders, all of whom are physician scientists who treat patients as well as do translational sciences, a bunch of them from Einstein, Montefiore up here, work on blood cancers. The one prominent person also I want to sort of mention here is Alan List. He is a prior CEO of Moffitt Cancer Center. Those of you who know Celgene that got acquired by Bristol Myers Squibb for over 70 billion, plus more if you take that into account, for a single drug that really made the company big was Revlimid, and of course the company got a lot more done. Alan was singly responsible working with the company and the FDA, putting together some very novel endpoints, not the novel endpoints of tumor regression or survival, but independence from blood transfusion, which is unheard of in oncology, to get that drug approved for the first time for a disease called myelodysplastic syndromes, which is the first focus of our company. We are also trying to bring in other board members, independent people to advise us who have industry experience. We brought on one who has significant experience, having worked at Bristol, Pfizer, as CBO in smaller companies, to help us get into big pharma. Our strategy for this company is a little bit different. We are seeking capital, from ultra high net worth individuals and family offices, as well as big pharma. We have decided as of now not to go traditional VCs, which of course, never say never in our business. We are in active discussions with a lot of big pharma. Actually, I flew in last night from the biggest hematology conference in the world, American Society of Hematology from San Diego. Some of my co-founders flew in this morning, and we had multiple meetings with big pharma. Of course, those discussions take a lot of time, but in the same period, we want to keep running, not move, not just walking and running and getting some of the drugs that we're working on into the clinic in patients ASAP. In 10 minutes, Marty took away my 5 minutes. No problem. I'm not going to convince you of my science and what we are doing.
No, you've got 10 more minutes.
Yes, I said you took away 5 minutes. That's what I was saying. Give me 20, but it's okay. I'm not going to convince you of all the science. I'm going to be showing you, and that's for future discussions and as diligence is done if you're interested. But I just want to give you a glimpse of why we're doing what we are doing and why we think we can get there, given our experience. I already told you we have significant experience both on the corporate and on the science side. And I do want to mention our founders have already also started another company that is funded by a VC firm. But this one, we really are very, very mission driven to get to the clinic to these patients. There's a lot of deep understanding of the disease models, and the patients, which is a little unique. Having been in biotech myself, when you have starter teams, they are pure scientists. They really haven't seen patients or touched patients, and then they bring on teams as they get along. But I think what truly differentiates us, if you look at other companies, is we have people who see still patients on a daily basis, and I'll share data from their own patients, the samples that they've taken out, and they conduct science in their lab and now drugs together. And we're trying to work this and move this forward fast. So the disease areas of interest are driven by the target that we've picked up. It is a brand new target for drugs. It's first in class, a target called S100A8A9. Most of you probably wouldn't have heard of it. However, there's a lot of papers published through many, many years, but people haven't been able to drug it. We think we have drugged it driven by biology, which is to drug it to both A8 and A9 together. People were either focusing on one or the other. So I think while AI and everything is great, biology is complex and it has to be really driven by biology if you're really going to go into humans and treat these diseases. Our core competencies of founders is blood cancer. So not surprisingly, that's what our first focus is going to be. Myelodysplastic syndrome, which is emerging more and more as people live longer. And I'm sure some of you have been touched by people who've had this disease, myelofibrosis. If you follow the most transformative treatments in cancer, it's immuno-oncology, immunotherapy, anti-PD-1s. However, a very small fraction of patients respond to it, 20 to 30%. And most of the patients don't respond. We think we know why they don't respond because of the immunosuppressive tumor environment. And this is the target that would help there as well. So solid tumors is another big focus. And others, which is outside a little bit of our scope, and hence we want to partner with big pharma, are diseases such as idiopathic pulmonary fibrosis, very, very bad prognosis, autoimmune diseases such as IBD, and this target has been implicated in Alzheimer's as well. This would all require the muscle of big pharma to come in early on with us. We certainly can do focus on blood cancers and take it forward on our own. And hence, that's our strategy of talking to them. So this just gives you a glimpse of, I'm not just making it up. We have data that we've generated in-house, certainly driven by our core competencies, which is in the circle in the center, and others we are working out, and we don't have monies in the company yet. We just started this company, but we will certainly, we have big ambitions, and we want to bring in all partners who are in it with us. I do want to give you a little glimpse of the diseases we're targeting and the data. I'll make it quick. MDS is a type of blood cancer where patients really have very low blood counts, anemia. And for high-risk patients, it actually progresses to leukemias very quickly, and patients die in less than a year. And as you progress, you can see the older you get, the higher chances of you getting MDS. People talk about lung cancer, breast cancer, but this is a disease. Look at the survival. Even in the low-risk category given by the purple bar, it is just 5.7 years. And once you get to the high risk, you don't even have 0.4 years versus lung cancer on the left. So there is a huge unmet need and just 1 or 2 drugs approved in the last few years. This is the target. Again, a lot of science, a lot published, but not well known because they haven't been drugged. It's a heterodimer. 2 molecules come together, bind to a number of receptors on suppressive immune cells. So if you block it, like we feel we have with our drug, you are able to activate the right kind of immune response to go fight cancers. So even with a lot of cell therapy, as you may have heard, you go and stimulate the body's own immune system to fight the cancers. Within the tumors, there are cells that are suppressing it. And we think with our antibody that we've made, we can reverse some of this suppression and make the immunotherapy work even better. So I do want to say, this is not work from us, but the target has been around, publications. Patients who have high expression of this target in this disease, MDS, they really do poorly. They die very much quicker than the patients who have lower expression. This is another disease called myelofibrosis, another kind of blood malignancy, where again, very high levels of this target are found. You can even see it in the blood versus healthy volunteers, I should say, not patients, where again, the marrow is filled with fibrosis and these patients get infections and disease. We have a first-in-class antibody program. We have generated antibodies in rabbits, chimeric human rabbit antibody that we have now humanized. I won't go into the details. We certainly can show you this, these antibodies bind what they're supposed to do, block what they're supposed to do. We have a portfolio. It's not a one-trick wonder. We do have antibodies that have slightly different attributes, so we can take them into different diseases, cancer, autoimmune diseases, AD, to say, to give you an example. Again, it acts on multiple receptors, blocks them, a lot of data that we've generated. This is one slide I sort of want to show you and say, and give you an idea. You have to believe the data when I say this, because there's not enough time. These are all patient data. These are cells taken from either marrows, bone marrows, or the blood of these patients. MDS patients don't make normal blood cells because their marrows have been filled with undifferentiated cells. They have these diseases. They're not able to progress progress in a manner to produce normal cells. So you don't get this. They have anemias, they have cytopenias, they die of infections. So when we culture these cells from patients and treat them with our antibody, we are able to make these cells differentiate into normal cells. So these just show that patients who had only 5.2% in our in vitro system, you could get up to 9%, or in some cases even up to 50% of normal cells. So you normalize their blood cells such that they would get rid of the disease and these patients can live healthier. The other thing I want to say is, as you probably know, a lot of these cancer patients have different mutations. People are making drugs to very specific mutations, but this is just 5 patient worth of data. We've had many more patient worth of data. Irrespective of what the mutational status of these patients is, our molecule seems to work everywhere. And which is not surprising, because we're not tackling the cancer cells, but we're tackling the immunosuppressive tumor microenvironment to make them go to the right direction. The other disease, multiple myeloma, I do want to touch on this. This is a huge collaboration we've established with Mount Sinai. If any one of you have known people with myeloma, it's one of the biggest centers in the world. They do cell therapy as well as other newer therapies that have come out. Yet, the only therapy that is curative still is bone marrow transplant. And the risks of bone marrow transplant are very, very high. Sometimes you die of the transplant and not of the disease. So again, we just presented this data at this American Society of Hematology meeting. All I want to show is there are patients who benefit from these therapies, immunotherapies, but there are patients who just drop and die. And we know the reason being that this molecule that we are trying to attack, S100A8A9, is present in very high amounts of patients, very high amounts in patients who die in the red. And if we treat the cells of these patients with our antibodies, again, not going into details, we are able to rescue the effects of the therapies that weren't working, such that these patients can start responding and then strive towards a cure. Cure is a word that we use very loosely in our daily lives. But, if we can make cancer into a chronic disease, not just a cure, just like heart disease, diabetes, blood pressure, that would be a huge win. So you really need therapies that are effective and safe. We think our therapy should be safe as well, because if you knock the whole genome out for this gene from mice, these mice live normally. There are no effects. So we do feel like, in addition to it's not chemotherapy, it's not any other toxic therapy that is targeted towards these cancer cells, but trying to put the balance of the immune system such that you can effectively eliminate cancer. In the interest of time, I'm not going to talk about more of these data, but just to sort of give you a sense of a couple of diseases. But most of the data that we've generated, we've taken cells from patients. You would ask, why not animal models? There are no good animal models, although we do have now a mouse antibody that we're testing in animal models. We make antibodies to human proteins, and the proteins in mice and human are not the same. So while you can do a lot of studies there, which we are doing with making murine antibodies, if we don't get to the patients fast, I think we can go in circle a lot of times for years and years. So this is sort of our timeline. We're very close to nominating our clinical candidate. And the next 12 months would be spent, and a lot of money spent on manufacturing the drugs to take it to a phase 1. If you have antibody-based drugs, it takes 12 months and $10 million to get there. That's not even talking about the toxicology work in monkeys and others. We're looking to bring in around 35 million such that we can get to phase 1 studies. We don't need to do healthy volunteer studies. Our first study would be in patients, and we should be able to see the effect within 8 to 10 weeks, which is transfusion independence, just blood transfusion independence in MDS. And we can be more ambitious and bring in more cancers, but that's sort of where we are. And happy to take.
Is there a timeline of this raise, or is it linked in a tranche?
So we are willing to do tranches. I think the pharma would take a little bit longer. We are under CTA with 4 of them right now. But we really want to get started on the manufacturing. I think this is the rate limiting step, so while we do other things, this has to get started if we want to get to our timelines of 2026 first half into patients. So we're willing to do tranches, absolutely, anything under the door. Right now, work is still continuing by discretionary funds to the founders coming from philanthropy. So we are looking into a venture philanthropy, family offices, and pharma at this time.
Have you looked into any grants? At the start of the day, we mentioned that NIH is in the city for some meetings. Several are going tomorrow.
Yes.
The next 2 days they're here.
Yeah.
Yes.
I work for DARPA and others, and a lot of stuff going on, the blood stuff.
Yes, so DARPA or ARPA-H are the 2 bigger grants. The smaller grants are really not worth it. It's like too much effort into getting a $500,000 check from the government. And the other thing is, if you have strings attached to the government, sometimes it takes much longer. Having been that, working with ECOG, SQUAG, like when they run trials, they do a great job. And again, our founders have been participants, but we want to move fast, so we are exploring some of these. Some of them are very political, ARPA-H and all, I'm very familiar with those. But we just want to get in monies with people who share the mission. Yeah.
1 floor down is the Ludwig Cancer Society, the Cancer Research Group, and then in the middle bank of elevators here is Memorial Sloan Kettering.
Yes.
They have their corporate headquarters, and Mount Sinai is a big client.
We know all the folks at
They're 2
Sinai,
blocks away.
and the myeloma data I showed was from Sinai. So we're looking at actually a meeting with the Multiple Myeloma Research Foundation. They have a venture arm as well, so we're looking into that. Yes, from the center's perspective, we know all the blood cancer centers. That's not an issue to mind. Yeah.
So and this molecule addresses all myeloid-driven diseases, not just cancer?
Yes, that is the key.
Because I think that there's a lot more occurring. I
Absolutely.
think I read 13 out of 100,000 cases versus, and I think the cancer is about 2 out of every.
Yes, you're absolutely right. Why did we pick cancer? Because that's the lowest hanging fruit. You can start seeing activity in phase 1. If you have to go into IBD or autoimmune diseases, you have to do a healthy volunteer study. But you actually, it's pretty savvy of you to pick it up. Yes, it's myeloid-driven diseases, irrespective of what they are. S100, A8, A9 is the biggest inflammatory mediator produced by these cells, and these cells proliferate in response to this molecule. So yes, it is across many diseases.
Sometimes you run into these therapeutics and they end up being like a platform.
Yes, so that's what we like to position ourselves as, a platform to target myeloid diseases, inflammation, and cancer is sort of how we want. Yes, you're right. And we have different antibodies, so we just didn't generate one molecule, but they all target the same molecule.
What kind of intellectual property do you guys have?
So we have, so the IP is to the antibody sequences. So we have, so Einstein, where one of our founders made this, has the IP, which we have licensed all into the company. And as we speak, we've brought in another molecule into the company along the same pathway, but a different target. So we have actually 2 different targets sort of working in the same mechanism, through the same mechanism, but we have the intellectual properties now within the company.
Right.
Yes.
Who will do your manufacturing, your GMP manufacturing?
So We are talking to Wuxi with the Biosecure Act looming. However, it seems like that the Biosecure Act in its current form is not going to move forward as of 2 days ago. And we've been in touch with the Massachusetts governor and all, who didn't even support it in the House, and now it's with the Senate. And that was also a discussion, right? What are the implications of China tariffs and the Biosecure Act? There are no not enough CDMOs in the US. In my previous company, we had another big player, Lonza, but you need people like Wuxis in the world for companies like us who are amazing and can deliver, or alternatives here. So yes, but Wuxi, Lonza, Wheeler Bio, and other smaller Catalent are some of the regular players. None of the biotechs or even a lot of big pharma manufacture these biologics in-house. You cannot, yeah.
And so all this is being done in the US, or is any of it being done in India, or coming out?
No, 100% US. The science is complex. The assays have to be developed well. Your drug is as good as the assay. So it's garbage in, garbage out in the world of biology. If your assays are not good, you'll not be able to flush out the real molecules. We cannot outsource our assays at all. It's been developed in our founders' labs. This has been a work of 3-4 years, and now we've put it in a company and licensed the IP. Yeah.
Do you own the underlying molecule, or you have to license the molecule?
You just license the sequences, amino acid sequence. So we own the molecule for all practical purposes. We own the molecule, and we may give Einstein a little equity stake and like maybe a little royalty down the road. Yeah, and Einstein's been very supportive. That's where the primary founders work. We may actually license space and their animal facility to do the work. Having built animal facilities in my last company, I can tell you, it is not easy or right value for the company to start investing all of that if we can get started elsewhere.
Great. Well, that's fantastic. Great job.
Thank you.